before. I can walk you through how to change the Outlook settings so it never happens again.
Yeah, it's
You're not
happened
the
to me
only
too.
one.
Yeah, it's happened to me also.
Okay, hold on a moment. Sorry. So I'm just waiting one. Are you still open, Jonathan, on the,
Yes.
okay.
I moved Emily over here, but no one else so far.
Oh, okay. Okay, anyway, I see it's 1:03 now, so we might as well get started. Okay. Sorry, I got thrown off there. Okay, so I guess Leo is better than Leonardo. I'm not sure.
Yeah, Leo's good.
Leo, so Leo's an assistant professor in the Department of Epi at Boston University. So at first we actually discussed, your recent IPD meta-analysis in children, but I think we've settled now instead on your second favorite topic, or maybe your most favorite topic at the moment, which is tuberculosis in transmission dynamics in high-risk populations such as prisons. And so today you're going to give us a kind of an insight into what's going on in some of the prisons around the world.
Yeah, thanks.
What can be done? Go ahead.
Let me share my screen here. See if this works. All right. All right. Give me one sec. Okay. All right. Can you hear me okay? And see that okay?
I definitely can.
Okay. So thanks for the invitation to speak here. It's really exciting to be here and talk about some of this work over the past few years. And as Dick said, generally my research really tries to use different study designs and epi methods to try to understand neglected populations. So children, people living with HIV, and people that are incarcerated. So, and that's what I'm going to talk about today. The last one is some different research that has come out on TB in prisons, and with some focus on Central and South American prisons in Central and South America. So prisons are really this perfect environment for transmission of TB, and most of this is due to institution level reasons. So crowding, poor access to healthcare, ventilation. And then I think there are also other factors that people often think are, individual level reasons, but I would argue these are also institution level reasons. So malnutrition, drug abuse, tobacco use, HIV, all of these increase when people go into prison, and rates go way up when people enter prison. So there's a lot of institutional level reasons for really high rates of TB in prisons globally. And so I would argue, or I think pretty confidently, that almost everyone in the TB field would say this is a really high risk population. Probably not a lot of argument there. But I think despite that, basically unanimous agreement, this is really a historically neglected population, both for TB control generally, and then also in the wider TB fields, including in research, I would say. And so I think what happens is when you have a neglected field like this, you really lack data to try to inform interventions and try to inform policy and advocacy. And so this is a little bit, I'm going to delve into this a bit. But just to give an example, this is like the WHO report, all the national TB programs, ministries of health, that many of them look at this document as what they can do for TB control in their country. People that are incarcerated mentioned twice in passing, mostly as part of a list of other groups. Same here in 2018 and also 2019 here. So really not a real global priority, or even in many regions, not a regional priority for TB control. And so this creates this system of neglect where this article is almost a decade old now, but I would say it's pretty similar, where it's difficult to conduct research in prisons, to implement interventions. if there's no guidelines and no recommendations. So a lot of people that work in this field, it's mostly, there are so many gaps in knowledge that really the goal is to try to fill some of these gaps to try to inform policy and help advocacy. And that's a little bit of what this research is trying to do today. I'm going to present. So I'm going to present 3 different projects, if possible. We'll see if I get there. But the first one is a meta-analysis of TB, of all TB studies that have been conducted in prisons. I'm going to talk a little bit about work in Brazil, working in 3 prisons in Brazil over the past few years. And then the third one is work with PAHO, looking at prisons across Latin America, and then talk a little bit about other work. So last year, we published a study in Lancet Public Health, trying to compile all the available literature that's been published on TB in prisons, to try to understand a bit better what we currently know. And so hopefully that can inform what we do in the future. So this was a pretty large systematic review, 141 studies. We included different outcomes. So we included prevalent disease, incident disease, and incident infection. 92 on prevalent, 48 on incident, 11 on incident infection. This was a large group, multiple people going through the data and looking at these different articles. And really, you know, I work on TB in prisons for a number of years now. And despite that, these results were pretty striking to me, I think. This is incident TB infection rates in 11 studies, different countries. These are conversion studies. So the studies had to include people that were negative on either a tuberculin skin test or some type of IGRA, and then follow up for conversion over time. And you can see here the rates are extraordinarily high. The x-axis is the incidence of conversion per 100 person years. And you can see that the pooled rate, it's highly heterogeneous, but the pooled rate was 15 conversions per 100 person years. So roughly, roughly converted that to around 15% annual conversion of a skin test or an IGRA test. So just super high rates. But there was also wide heterogeneity. So you can see here in studies in Brazil here, there's another study in Brazil, Colombia, Iran, and another study in Brazil. Rates were higher than 15 conversions per 100 person years in all of these studies. And some studies had much higher. So these studies in Brazil, 60 conversions per 100 person years. This was conducted by our group in Brazil, 43 conversions per 100 person years. Just super high rates. I've never seen such high conversion rates among really any population. And then there were some studies, Australia, Spain, the US, where conversion rates were understandably lower, between 0.5 and 6 conversions per 100 person years. You know, these are still pretty high. I think these are low burden countries, and you have a study in Australia having 6 conversions per 100 person years. So super high rates still, but I do think there is this heterogeneity here, and you know, it really suggests, you know, not surprisingly, that there is really this spectrum of TB epidemics in prisons around the world, and so we're going to delve a bit deeper into that as we move on. So these are prevalence and incidence results from this systematic review. It's a little tiny here, but the rates are again super high. For example, you can see here, this is the incidence. Incident disease per 100,000 person years was above 2,000 per 100,000 person years in the African region, above 1,500 in the Southeast Asian region. Many regions had prevalence and incident rates above 1,000 per 100,000. So, and the incidence in prisons clearly goes up as the national TB incidence goes up. You can see that here. These are studies in the WHO high burden countries. You can see drastic disparity here with incidence rates, also disparities here with prevalence rates. And then if you look at here, as TB incidence in the general population goes up, the incidence in prisons goes up. So starting at 40 cases per 100,000 person years in prisons in countries that have less than 10 cases per 100,000, going all the way up to 2,000 cases per 100,000 person years in countries that have much higher burden in the general population. This is just very similar, just presented graphically. This is the general population incidence on the x-axis in log scale. And this is the incidence in prisons, again on log scale. You can see that in settings that have a low general population epidemic, the epidemic in prisons is also lower compared to populations that have a higher TB incidence in the general population. And there's this real clear trend here in these studies. We also wanted to compare TB incidence in prisons compared to the general population overall. How much higher is TB incidence in prisons compared to the general population? And so in these incidence studies, in these, there were 47 incidence studies where we could calculate this, and we found that incidence in prisons was around 10 times higher than incidence outside of prisons. But there was also pretty wide disparities here. So in South America, the incidence in prisons was 27 times higher than the background burden. So much higher. In North America is 4 times higher. So still much higher, still much greater, but nowhere near some of these other regions. And you can see also income disparities here. Countries that are higher income had a 5 times greater incidence in prisons compared to the general population, but much higher in lower income settings. And so this really made us ask, what exactly is happening in Latin America? Is this specific to these studies? Could we understand this better in our field work and in other research that we're doing? And so we I've been working in Brazil for a number of years now, doing some field work in 3 prisons in Brazil. Brazil has a very large population that's incarcerated, only behind Russia and China, and currently has around 700 to 800 people incarcerated. And here you can see one of the prisons that we work. This is the largest prison in the state where we work. This is the state where we work, Mato Grosso do Sul. This is in southwest Brazil, bordering Bolivia and Paraguay. And just to give you a few, pictures about what exactly these prisons are like. This is a bit of a closer look at the prison cells where we work, the environment where we work. You can see that there's incredibly high crowding. Many cells have 10, 12 people that are incarcerated per cell. And so you can see that this is really, if someone with TB is in these cells and not diagnosed, you can see how it could spread extremely quickly. Similar here, these are the hallways in one of the cells one of the prisons where we work. You can see ventilation is extremely poor. This is one of the isolation rooms where we work as well. So really poor conditions in these prisons where we work in Brazil. And so I think, interesting, something we've discussed a lot with the group I work with is what interventions would really work in such a setting where transmission is so high and the burden is so high. And not all interventions may have such a large impact when they may have an impact in lower burden settings. And I think what this, what a lot of this comes down to is, again, coming back to the fact that we are really limited with the data that we're working with. And so to inform interventions, we're really in a testing phase. And so right now, we're doing mass screening in Mato Grosso do Sul in 3 prisons there. You can see here, this is a mobile chest X-ray van that goes from prison to prison, depending on when we're doing the mass screening. You can see here that this is a person from one of the prisons getting an X-ray So really good conditions in this with this mass screening that come with this, very different than what you normally see in the prisons. And so I think the idea of this specific intervention, which I'm going to discuss a little bit more, is to try to tackle one of those reasons for why TB in prisons is so high, which is poor healthcare access. At the beginning, there was a host of reasons, and this is really trying to improve healthcare access in the prisons and try to diagnose cases much faster. And this mass screening is multiple rounds of mass screening. There's going to be 3 rounds in total, and 2 of the rounds have completed. I actually think the 3rd round is wrapping up. And the idea is to perform symptom screening, X-rays with CAD4 TB, culture and gene expert on all people that are incarcerated in these 3 prisons, regardless of symptom status, regardless of any real status, just to do widespread screening. And in the first round of screening, there were 5,437 people incarcerated, and we found a prevalence rate of 3,900 cases per 100,000 persons incarcerated. So almost 4% prevalence rate in this first round. So pretty extraordinarily high rates. And cough and TB-related symptoms were very common. I think something really important about this specific population is that obviously very different than the general population, much more likely to smoke, much more likely to use drugs in the past year. I think 60% of people incarcerated were smokers. And so what happens is prevalence of TB symptoms goes way up. And so 40% of the cohort had symptoms. Those with symptoms comprise over 80% of all TB cases that we found. And it really questions the idea, like we're questioning maybe everywhere in all settings, of symptom-based triage in the context of mass screening and how it really could perform in this setting. Although it did identify a lot of the cases, you really need to do a lot of screening because most of your population, or a lot of your population, is symptom positive. 17% of the cohort had a CAD4 TB score above 60, indicating TB in this population. And this comprised almost 80% of all TB cases. And there was also wide heterogeneity between prisons. But I mean, pretty high in all prisons as well. So there, as I said, 3,900 cases prevalence per 100,000. But in Maxima prison, which is the highest burden prison, it was 5.5%. So 5,500 prevalence per 100,000. And in Penal, the lowest burden in this prevalence screening, it was 2,300 cases per 100,000. So a spectrum there for sure. And I think something that we obviously knew about, but definitely is different than other mass screening interventions in other places, are the fact that this population is very mobile, is very, there's a lot of in and out flow in these prisons. People have fairly short incarceration durations in Brazil specifically, but actually all over the world, really, and definitely in Latin America. The average duration of incarceration in Brazil is around 1 to 1.5 years. And around 1 in 3 people, I think it's 34, 35% of people in prisons are pretrial detainees. And they're often kept in prison before they receive a trial, often lower socioeconomic status. They can't necessarily afford good representation, so they're often not released. And so due to this, they're in prison for months and months before they receive a trial. So this is one of several reasons why incarceration, the duration of incarceration is so low. And so the relevance of this to the mass screening is that a lot of the people in the 2nd and 3rd rounds of mass screening are completely different populations to the ones we screened in the 1st round, even though we're screening the entire prison. And so it really creates a different dynamic than you might see when you're doing mass screening in other types of populations. So this is just a social and environmental dynamic that we have to deal with in understanding our future interventions. So obviously we understood this, but I think the context of this within our intervention, is difficult to exactly understand until we finish all these rounds of mass screening. And so we've seen the studies from the meta-analysis work that really suggested Latin America was an important region. And then this work in Brazil with these hyperendemic prevalence rates, 4% and above, that prisons in Latin America were really concerning. And I think, so part of my work has also been to try to understand what exactly is happening in Latin America. Is it specific to these studies in this meta-analysis, or are there other reasons? And if it's super high in Latin America, higher than other places, why is that the case, or what could potential reasons for that be? So that was part of some other work that we recently published. And just to zoom out a little bit, globally, there has been an increase in incarceration over the past few decades in almost every region of the world, except for Russia here, and some stagnation in Europe without Russia. But you can see here that overall in every region it's increasing, but but in the Americas, not including the US, incarceration has been increasing the most, with over 110% increase in incarceration over the past couple of decades. And so, this may not be obvious, but the amount of prisons in Latin America has not been increasing. And so the amount of crowding in these prisons has been increasing as well as the incarceration grows. So this is just, this is the absolute number of incarcerated people in thousands in South and Central America, and divided by different countries by color. And you can see here that the absolute number of incarcerated people has been increasing since 2000, continuously over time in South America, going from around 300,000 to well over 1 million in 2016. Really similar in Central America, slightly lower numbers, but going from around 70,000 to over 160,000 in 2016. So 250, 300% increases in incarceration in just a decade and a half. And you could say maybe this is because the population overall is growing. And so the population that is incarcerated may also be growing with the general population, but that's not the case. This is the incarceration rate per 100,000 people in the general population. You can see, this is South America. You can see that the incarceration rate is increasing in almost every country in South America. Pretty drastically. If you look at Brazil is dark green here, just super high, steep increases in incarceration during this time period. Similar in Central America as well. Almost all of these countries saw increases over this 2 decades in incarceration. Just want to point you to El Salvador here, which had incredibly high, steep increases in incarceration. And we're going to zoom in a little bit on that in a few slides. And so I worked with Marcos Espinal, who's the director of infectious disease at PAHO. I actually worked with him on the pediatric paper that Dick mentioned. And so I reached out to him to see if he wanted to collaborate on this topic as well, on TB in prisons, because we thought he was really a person that would have an interest and have the ability to communicate with different countries to try to investigate this. So we wanted to understand TB notification rates, TB diagnoses in Latin America in prisons, to understand this a little better. So we went to every country with PAHO, and we requested certain data from country level officials in the ministries of health. So we asked for the number of people incarcerated that were diagnosed with TB, what year they were diagnosed, and some countries provide additional data on TB and HIV, location, like which prisons. And then we also asked for incarceration level data. So how many people were incarcerated at the country level? We got this from other sources as well, but and then crowding at the country level as well. And so basically the idea here is, can we create notification rates over time in prisons in this region? That's the very basic idea. And we had, we had success. I mean, I think I'm not gonna say it's all me. I think a lot of this is PAHO, having really great connections with country level officials. And so when we were able to collaborate with them, it really gave us some help for sure. We received data from almost every country in Latin America. Here you can see a map of the most recent year of data on the TB notification rate in prisons from Latin America. You can see here that the notification rates are extraordinarily high. Several countries diagnosed over 2,000 TB cases per 100,000 people incarcerated. Peru, El Salvador, Bolivia, others, and most, or I would say almost most countries had over 1,000 cases, incident notifications per 100,000 people incarcerated. And so I guess, I think important to mention is that this isn't true incidence. These are just notifications, just diagnoses. So the true incidence is actually much higher than these notification rates, which is pretty concerning. So this is probably the bottom end of the barrel here. And so how do these numbers compare to the general population in these countries? You can see here, this is the incidence rate ratio. And you can see the prisons and people incarcerated in every country had much higher rates than the general population. In some countries, drastically higher. So El Salvador, Venezuela, 75 times higher in prisons than the general population. But even in other countries, Ecuador, Honduras, Peru, it was 30, 50 times higher than the general population. So these are extremely high risk prisons, even higher risk, I would say, than other areas of the world. We want to understand what was the proportion of TB occurring in prisons. So a lot of the data that I've shown before is a bit more maybe individual level risk of being diagnosed in prisons. We wanted to understand, what did this have to do with the overall epidemic? And this is the percent of TB in prisons nationally over time in different countries in South America. You can see, this is the percent here, this is time. You can see that the percent was very high in many countries. So Brazil, Venezuela, Paraguay, the percent of TB among people incarcerated was above 12% in the most recent year of data. But maybe more concerning is that it's going up over time. And I think this could potentially be due to what we were discussing earlier about incarceration growth in the region as well. In Colombia and Venezuela, you see these sharp increases over the past 3 to 4 years. Here you can see Venezuela, 2008, around 1 to 2% of TB in prisons nationally, goes up to 3% in 2015, and now it's 14, 15% in the most recent year of data. So super high proportion of all TB that is located in prisons, of all diagnosed TB, I should say. And as a region in Latin America, 11% of all notified cases in Central and South America occurred among people that were incarcerated. And this population is below 1% of the overall population. So you can see here that there is huge epidemics occurring in these very small populations that are incarcerated. And this is really trying to demonstrate something similar, trying to look at the impact of this on country level TB epidemics throughout Latin America. I'll just walk you through this really quick. The red bars are incarcerated people that are incarcerated. And the blue bars are the general population. The x-axis is the change in notified TB cases from 2011 to 2017. So if you're on the right end of 0 here, you've had an increase in notifications over this time period. And if you're on the left side of 0 here, you've seen a decrease during this time period. And you can see that in every country listed and in South and Central America overall, the red bars are on the right side of 0 for every bar, which means there's been an increase in notifications during this time period in people that are incarcerated from these regions. And here you can see individual level countries. I'll just zoom in on a couple of them. You know, Brazil, we talked about a little bit earlier. You can see that the general population epidemic in Brazil has decreased from this time period, slightly decreased by some hundreds of cases. So not a huge decrease, but a decrease nonetheless. But the increase in people that are incarcerated is pretty substantial, 4,000, 5,000 cases. And so I think generally the message of this figure that I took away at least is that if we were to concentrate a bit more resources, a bit more of our TB control, at least in Latin America, on prisons, the increases that we could see at the general population would be much higher than you're seeing currently in Latin America. There's other countries that have other patterns here. So El Salvador, Colombia, Ecuador. You can see that there's been an increase in the red bars. So an increase during this time period among people that are incarcerated, but also an increase in the general population, and actually pretty similar increases in the general population, which really suggests that most of the increases during this time period in the general population are from people that are incarcerated. If that epidemic was really controlled, these notification rates in the general population would go back to 0 or close to 0. So again, I think the message is similar. And this is for the region as a whole. You can see that in the general population in both of these regions, there have been slight decreases in notifications during this time period. But the increases in notifications in prisons is drastically greater. In South America, almost 10,000 more cases in prisons in 2017 compared to 2011. So if, as a region, there was more emphasis on this population, I think we'd see much higher decreases here. Just to focus on a couple countries that were especially concerning in this project, El Salvador, as I spoke about, in the most recent year of data had above 5,200 notifications per 100,000 persons incarcerated. So over 5%, so pretty drastic. Some of this may be due to more increased screening as well as incarceration. I think probably the reasons are multifactorial. This is the prison population rate in the country over the same time period, which has gone up continuously. So I think there's probably multiple reasons for this increase, but regardless, the rates are crazy. If we look at Venezuela as well, these are the notification rates in Venezuela. You can see pretty stagnant rates from 2008 to 2012-ish, and then continuous increases and then some shooting up here at the top. Again, the prison population rate could be one reason for this. They had an economic recession as well. There's probably many reasons. Regardless, I think we need to find interventions that really work for these populations. So I think this project really highlights that there's this really huge, serious problem in prisons in Latin America. I think at least one of the reasons that we can confidently say is this increase in mass incarceration over time is one of the reasons that could be potentially leading to this, but probably several reasons. And I think also these increases of TB in prisons in Latin America are threatening TB control in the wider epidemic in the Americas, at least in Latin America specifically. And that there should be clearly more focus on this specific population. Some outputs from this work. I think this is my, this project was one that I worked more with a health organization, a global or regional health organization than I've done before. And it was really great. PAHO is really a great partner in this work. And I have to give them a ton of credit. They really realized this is a huge problem from looking at this data. They made several changes after this project. So the first is that they started to mandate reporting on TB in prisons from countries in the region. So now, I think 2020 or 2021, I'm not sure which is the first year, but that's the first year that there's now mandated reporting from every country. I think they also include, they collect data on TB in children, TB in people with HIV, as the WHO does, but now they also include people that are incarcerated. They also organized a workshop with all country level officials. So all ministries of health, national TB programs, other stakeholders, to talk specifically about TB in prisons in the region and talk about potential solutions and what gaps there really are. And I presented some of this work at that workshop. And this has led to a working group to try to write specific regional guidelines on TB in prisons in the region. This workshop was last year. I think they're working on the guidelines. I think they're wrapping up, but I don't think they're published yet. But it's pretty good from a policy perspective, not bad output. And I think hopefully, especially this mandated reporting, as I said earlier, one of the real problems with working in this field is that we really lack data. We really would love more data to try to inform different stakeholders and to understand the epidemic better. And so I think these kinds of changes could make real big impacts downstream. So I'm just going to conclude on these three projects and then talk a little bit about future work that I'm working on that should come out soon, I hope. But what do we know? Rates of TB are between 10 and 40 times higher in prisons compared to the general population, depending on the location and the exact prisons in which you're located in. And in some countries in Latin America, they're even higher than 40. Increases in mass incarceration are likely fueling the TB epidemic in Latin America. And I think we really need further research on TB specific interventions such as mass screening. We found a very high prevalence rate in our mass screening that we're doing currently in Brazil, but we need to know more about what multiple rounds of mass screening are going to do, if that will reduce prevalence over time. And there just isn't enough data out there. I think also something else to consider here other types of interventions that may be specific to this population. So after COVID, there was a lot of decarceration in many places of the world. And potentially those types of interventions that are not TB specific per se may have huge effects on TB. I think decarceration in different regions was very heterogeneous, and a lot are not currently decarcerating anymore, a lot of countries. So some of those changes may be very different depending on where you are. So I think I talked a bit about neglect, and I think it's a bit of this domino effect where there's lack of data, which may hurt our ability to understand what interventions work, hurt policy, and then hurt advocacy. And there needs to be a bit more prioritization, I hope, from some of this work among this population. And so some of the future work that currently working on, I think this work with PAHO we felt was really successful. And I think one of the real surprises of this work was that the data was available. The country level officials had data on this topic. I think, and maybe this was a naive assumption of mine, this data isn't collected by WHO or PAHO or other global health organizations. So I figured that data wasn't available. But actually, it seems to be available from a lot of countries. And so we wanted to see, could we expand this work that we did in Latin America more globally? And so over the past few years, there's been a lot of work on trying to understand TB in prisons globally. Can we understand that better? A lot of collaboration, people at the Union, WHO, PAHO, Euro CDC, all of these groups trying to bring them together to try to contact country level officials to understand this a bit better. And again, like PAHO, like what we experienced in PAHO, this was largely a success. In the end, we had, so I reached out to country level officials from all 195 countries. And we received data from 151 countries. So good portion of good representation here, which included almost 10 million people that were incarcerated. So currently there are approximately 12 million people are incarcerated. So a good representation of all people incarcerated for notifications. And so our future goals with this work are to try to estimate global burden of notifications in prisons, global burden of incidents in prisons, and try to use all of this data that we've done over the past few years in this systematic work to try to estimate this. So systematic review that I spoke about here, where we have incident data and prevalent data, notifications we have here, where we have 151 countries, a lot of time trend data, and then incarceration level data, where we have incarceration from numbers of incarcerated people from every country. So we can have denominators and for our notification rates. So just basically bringing together multiple projects to try to understand more globally what's going on. And this is a bit hard to interpret, but this is just our data availability from this project that we're wrapping up. So pretty good representation from everywhere. The yellow is where we have data from all types of data. So incarceration, notification, and incidents from the meta-analysis. Orange is where we have just notification data and incarceration data. The red, these three countries here, are where we just have incidence data and the incarceration data, and then there are a few countries where we just have incarceration data. So pretty good representation, meaning we have data of some kind from almost every country. There are some countries where it's not possible, like North Korea. There's a few others that just weren't possible, although I tried, but was not possible. So this is just some future work that we're trying to do to try to, do further research to identify some of these knowledge gaps about the burden of TB in this population, and to help potentially policymakers and advocacy for this population. This was many groups of work. I presented this, but this was, I don't even know, tens and tens of groups working on all of this work. Yale, Stanford, Jason Andrews has done a ton of work in TB in prisons. Also Julia Crota from Brazil. I've done a lot of the Brazil work and other prison work is with him and his team, Roberto, Andrea, and Paolo. A lot of the global and regional work was with Tony Harris, WHO as well, and the whole PAHO team was huge here. Also, I worked with ministries of health from almost every country, and they were extremely helpful, and none of this work would have been possible without them. So thanks so much. That's all my slides. I'm happy to take any questions about any of this or discuss after.
Great. It's very sobering, very impressive data, but as you really. Okay, so we do have a few questions. Mayra has a couple of questions, and Marcel. But Mayra, do you want to go first?
Sure. Thank you very much, Leonardo. It was a very good talk. I'm from Brazil. I think you can realize by my name. But I have worked in prisons as a clinician in the past, and for me, I would like to know what's your interventions after mass screening. I have heard a lot of projects of mass screening in prisons, and of course, it's a gap. But for me, the biggest gap is how to connect these patients to the health system. So it was very common the patient not having like appropriated TB treatment, or the patients don't have it appropriated like HIV and TB treatment. So that was a very common problem. So I was wondering if there's any kind of like operational research, or how are you doing now in this specific prison in Mato Grosso after their diagnosis?
Yeah, so so you're saying after mass screening or alternative interventions to mass screening?
After mass screening, you
After
do the
mass
diagnosis
screening.
of the
Gotcha.
TB patient.
Gotcha.
So what's the next step for this patient?
So they're all, as part of this study, they're all referred for treatments. We follow them for treatments. They all go through DOTS in these prisons. Actually, in these specific prisons, treatment completion is not so bad. If we can get people incarcerated on treatment, it's actually pretty well received, actually, at least in these. So we don't have that problem specifically in these. I think where we do have issues is if people are on treatment and then they leave prison,
Exactly.
they're released. I think that's where we really lose people. And I think it's a really hard thing to do research specifically on people that leave, because understandably they don't want much to do with us anymore, right? They're gone, and they don't want to talk to deal with that anymore. So I think that's where we lose some people, and it's especially an issue for these prisons if because of the short incarceration periods. If they're in prison 6 months, 8 months, it may be in the middle of their treatment period. So the problem is we don't have great data on people once they leave prison. It's really hard to follow them up. You know, I think it's hard generally in any study, but I think in this specific population, it's super tough. So not a great answer. I don't have a solution, but it's a really good point.
Thank you.
I think one important thing to mention is that potentially one way around this is more through prevention, right? I mean, we can get around this issue if we prevent TB. So there's lots of preventative interventions that we have thought about and that could be put in place. Again, there's hardly any data on preventive interventions in prison. So, and I also just want to say that there's so much heterogeneity in prisons globally that interventions that may work in Brazil may not work in Vietnam or other places that have really big epidemics in prisons. So just to give you an example, I think what we've thought about is prison entry. Maybe prison entry is a good time period to implement interventions, because people are going from a very low risk setting outside of prisons, and then they're getting hit really hard once they get into prisons with this really high force of infection. So if we can prevent that transmission in that short window, maybe that could prevent them from developing TB but I think, again, not all interventions will work because the transmission burden is so high. They're getting hit with so much exposure that I think what exactly preventive interventions would work is an open question. I think if we give like a short course of preventive therapy, they might be exposed after. I guess there's lots of issues. There's so many, it's very complex, but anyways, really good question.
I just have a second question, sorry.
Yeah.
Because as you mentioned, like the prisons are very different between countries, and I have to say the prisons are very different within Brazil, very different.
Yeah.
So have you contacted is the national TB program involved in this, or like some kind of like a security department in Brazil be involved on this kind to expand it in Brazil?
Yeah, no, definitely. So Julia Crota was part of the Ministry of Health for a few years and has a lot of connections with the Ministry of Health, the National TB Program, and so all of our work is presented to the Ministry of Health. After we do it, we We talk to policymakers in Brazil to try to help them understand some of our study results. So it's definitely very communicative. I think there are things, there sometimes is tension between incarceration officials and public health officials. I think that is something that is difficult sometimes. Oftentimes they might see us as not as allies in a sense. So that's difficult. But government officials, we are definitely communicating all these study results to them and trying to advocate for more interventions and more funding. So,
Okay, thank you.
great question.
Jonathan?
Right, great talk. Super interesting. You kind of answered my one thought, that a question that came out of this is to kind of pair with the mass screening for TB disease, also screening for TB infection, and then provision of preventive therapy. I know you've brought it up, but I was curious if there was plans on this, because it seems like one of those where you showed not only a high prevalence on admission, a high incidence during their stay in prison, and then a high conversion rate, like 15% per year. And in a review we did, it was kind of like the progression rate among people who are in prisons was like 3% per year, so incredibly high. So it feels like this is one of those potentially untapped, but thing that could be grouped in with a mass screening intervention if you're doing it often enough. I mean, there's some evidence from like the Marshall Islands that these kind of repetitive interventions of screening for both infection and disease can bring down incidence rates. So I was wondering if that was something that not only just in your head, but something that PAHO or country level people were considering. And the second half of my question was, I mean, now with COVID's also been a massive concern and issue within prisons. Is there any talks to kind of put together interventions that are meant to prevent COVID? I think you're thinking of kind of reducing crowding, better air filtration, ventilation, that presumably would also help TB. Is there talk to kind of link these two prevention strategies together?
Yeah, great questions. So I'll take the first one. So this is on, pairing mass screening with preventative interventions together. Yeah, I think this would need to be tested through empirical research first. I think PAHO and country level officials are a bit more hesitant to put so many resources until we have some evidence that it works. I think the first step that we wanted to do is to try to test this mass screening first to see, does this work? And then definitely preventive interventions as well. So as I said, the incidence of conversion was around 15%. And actually in the prisons that I presented in Brazil, it was higher, it was around 30 to 40% per year. But if you took like a prevalence of TB infection, just a prevalence survey, prevalence rates would be 80–90% in these prisons. So what really, so I think a preventive therapy strategy would only really work, would be difficult to work if you just were to screen randomly, is what I'm saying, because most of the people in prisons would test positive through a TST or an AGRA. I think there's this gap that I said at the beginning, potentially. We don't really know if this would work, but at prison entry, before they get hit with this huge exposure time period, where maybe you could try to prevent infection or prevent progression, potentially. But that hasn't been tested, and I think that definitely needs to be tested, for sure. I think interventions for prisons are really heterogeneous also between countries and even within countries. A lot of countries do prison exit as a screening. When people leave prison, they screen them for TB, which may be good, if you're trying to prevent progression into the general population. I think that would be good, but it may not be good for trying to prevent TB in prisons because they've already been hit with so much exposure and progression rates are so high already. So you're not preventing much in prison. So what I would say was, I don't think anyone's doing that right now. I think there's talks of doing that, but they would have to be massive programs and really difficult. But yeah, I completely agree. And then, oh yeah, sorry.
So Marcel has two questions, but Marcel, we're almost out of time. So maybe you can take your best question, so to speak.
Sure. Leo, it's nice to meet you. I read the article and I was very interested. For people in the TB Center who don't know, when I was in medical school, I used to play basketball in the Kingston Pen with the lifers. And so I was wondering about the one-way prisoners who are incarcerated for a long, long time versus the transient visitors, which I think in your article you refer to as jails, and whether you think they have different rates of incidence of infection and disease, but also different rates of contribution to community transmission based on whether they're cycling in and out and whether there's linkage to care when they come out.
Yeah, great questions. So what I would say is linkage to care is difficult. As I mentioned earlier, it's really hard to follow people. There's a lot of incomplete treatment among people that leave prison in the middle of treatment. I do think the cycles in and out is really important for understanding transmission from prisons to the general community. I think there are definitely huge differences. And a lot of I think Jason is super interested in this topic and really wants to explore this more, is what is the contribution of TB transmission in the general population? How much of that is attributable to prisons? And I think it's really hard to study, but I think the contribution is not small. I think recent studies in Brazil are between 10 and 25%. This is a very high, this is a population with a lot of incarceration, huge TB epidemics in prisons. So it may not be like that everywhere, but in Brazil, where we work, at least the contribution is super high. Yeah, I think your other question was long durations of prisons. Are they different? I think they have places that have longer durations of incarceration probably have much less contribution to the general population, but that needs to be studied empirically. But that's really what I'd say. Sorry, I think we're over time, but.
Yeah, okay, thanks. We are over time, which Outlook always informs us, by dinging us for the next meetings, et cetera. But thank you, Leo. That's really impressive work. Definitely a neglected population, forgotten, whatever. Some of those photos are really pretty horrific, really. I guess, my thought, my question, but there's not really time to answer it, but it's just, in countries where they put so little into the prisons that they have such terrible physical conditions, are they going to put adequate resources into the medical care to do something about the TB? I suppose the studies of transmission to the general population and the impact on the general population might help motivate that.
Exactly. Yeah. There's a political lens for sure. Yeah.
Anyway, good, great talk. Very sobering, and really good luck. We'll look forward to inviting you back to hear what the interventions are.
Yeah, that'd be great. Thanks so much for inviting me.
Great. Thanks again, Leo. Terrific.
Yeah, great.
Thanks, everyone.